welcome to our DOMSE medical staff question and answer session. We're very grateful that we have the people on that we do, and that Bishop Nicholas has been able to help with setting this up. And thank you, Sayedna, for arranging this. My name is Michael Baclig. I'll be the moderator for this question and answer period. I just ask that everyone please make sure that you stay muted until such time as you have a question to ask when we ask for questions. It would be preferred with this many people on if you could ask your question using the chat feature. I do have access to the chat as the moderator, and I can ask the questions. I'll actually read them out loud and have our panel respond. Cool. We are also recording this for those that can't join us live. So if you have friends or a family member that was unfortunately not able to join this live session, we will be sharing the video as soon as possible after it has concluded. I wanted to go ahead and introduce our panel of medical staff. I'm going to start with Dr. Fadi. If you could just give us a brief introduction about yourself and your field, and I'll move on to the other two.
Yeah, good afternoon, Michael. Thanks for coordinating this symposium, and if we're going to call it a symposium, and nice meeting the other colleagues from other parts of the diocese. Yeah, I'm a pulmonologist in Lafayette, Louisiana, and I've been here as long as I could remember, more than 20 years probably.
Wonderful. Dr. Sergey, if you could go next, introduce yourself and your field as well, please.
Hi, thank you for having me and inviting me. I practice infectious diseases, and I've been in practice for 13 years since finishing up my fellowship in Chicago, and I practiced for a long time in Chicago area and just moved to Naples, Florida last year. So thank you.
Wonderful. And our third panel member today is Jessica. Jessica, could you also give a brief introduction, please?
Yes, my name's Jessica Tarabay. I have a background in epidemiology and infection prevention, and I've been in the field for about 9 years, and infection preventionist for 7 years. So, yep.
Wonderful. Thank you very much. If someone could just give us a brief chat message so I can make sure the chat is working. I'm sure I'll get a few different people. Yes, there we go. There's a test. So chat is functioning. We're going to go ahead and start out. I don't know if Bishop Nicholas, you have anything to say, or if you'd like to speak here before we begin, but I wanted to give you that opportunity, Sayedna.
I'd like to welcome Dr. Sergey, Dr. Fadi, and Jessica to this. And we look forward to listening to a very informative session. And we ask everyone to participate in it. If they have any questions, to feel free to ask. And I will turn it over to you, Michael.
Wonderful. Thank you, Sayedna. We only have an... Oh, go ahead.
Michael, a word to reply to Sayedna. Thanks for your leadership in being very responsive in setting up that within a few days, and we'll be here to assist as much as I can.
Wonderful. We're going to go ahead and officially start the question and answer session. So if you have questions, please type them in the chat box. If you're joining from your phone, there is the ability to select the chat. You may have to tap the screen and select chat at the bottom of the screen. Or if you are not able to chat, feel free to unmute and ask your first question, but please identify yourself when you do unmute. Okay, the first question we have for our panel is from Mark Santana. Should we be tested even though we don't have any symptoms? And Dr. Fadi, why don't you start with the response for that one?
Well, this is the big question. Actually, it's all over the waves, as you can hear it. I don't know if I'm going to be adding much in this. We are still in the learning curve of this.
Green tape.
issue,
We don't.
probably with the expertise of the epidemiologist, Dr. Jessica, probably she will have some more.
Yeah.
As far as I can tell at this point in time, if you are asymptomatic, that is, you don't have symptoms of cough, fever, or sore throat, you don't need to be tested. Now, we are learning more and more about this problem, is that you could transmit the infection when you are asymptomatic, but that is a complicated epidemiologic question. But at this point in time, what we know about it, and from a practical standpoint, is if you are asymptomatic, you do not need to be tested. I don't know if Dr. Jessica has another more.
Yeah, let's send it over to Jessica. Could you maybe expand on that response?
Yeah, so there still is a lot of data that we need to basically validate on asymptomatic transmission. Right now, the virus is droplet per se, as far as like infection transmission. So unless people have either a fever that's greater than 100 degrees, chills, cough, shortness of breath, difficulty breathing, sore throat, or specifically also loss of smell. Those are some new symptoms that are occurring. We're not recommending that people go get tested. We have quite a bit of a shortage in supply for testing, and so we really need to prioritize that. And so in a perfect world, yes, we would absolutely want people to get tested, but right now, just with clinics and hospitals just overburdened, we really don't have that bandwidth. So no, I would say if you are not symptomatic, do not try to get tested. Let's prioritize those. Now, if we move forward and we have enough testing in P-swabs, test kits, PPE, then sure, that would be a different conversation, but we're not there yet.
Thank you, Jessica. We have a lot of questions that are popping up here. Dr. Sergey, I'm going to have you start the response to this next question. The next question is, I don't have a name, but I have a compromised immune system and am housebound. When my husband goes out of the house, what does he need to do to avoid bringing home the virus? What about grocery deliveries or mailbox pickups? Dr. Sergey, if you could respond to that one, please.
And in this situation, the hand hygiene is important, since the husband is the only one that the person has contact with. So that's good. Of course, husband needs to make sure he is healthy, not having any symptoms. In regards to the fomites, the stuff that come in, potential is not very high. We do know that the virus can survive on surfaces. I think the common sense approach would be, when you opening up a package, delivery from outside, you wash your hands after you handle it. Make sure you don't touch your face in the process. I don't think you're gonna inhale anything off the box, but I think it's, if you theoretically it's possible. I don't think it's very likely. So I think in that situation, when you have one contact going outside, the main risk of would be that contact bringing something rather getting something from the box. So it still remains very important for the husband to be aware of the surroundings when he goes out, make sure that he maintains social distances so he doesn't bring anything back.
Thank you, Dr. Sergey. I don't know, Dr. Fadi, if you'd have anything to add to that.
Well, yeah, I mean, as Jessica said, this is contact and droplet mediated transmission, and they've looked at now those fomites, F-O-M-I-T-E. That is these objects where you can pick up stuff from. And I think the last issue this last week, New England, some people had the time and energy to study the rate of how long the particles or the virus basically lingers around 4 or 5 of those vehicles, let's say from stainless steel to copper to cardboard and to the aerosol. The problem is that not only droplets, that is where you have somebody coughing and you inhale that droplet, it lingers around in what is known as the aerosol. In our field of pulmonary, we give the aerosol, aerosolized or nebulized medications as routine of your breathing treatments, we call it. And that's a mechanism of delivery into the lung. So aerosols linger around a room a little longer in the air, not as a direct droplet. And Dr. Tarabay can fill in that part too. So they've analyzed those 5 vehicles or 5 areas of concern that they call it the fomites and so on. And they're looking at how long it lingers around and the rate of decay. So to make it simple on the questioning audience is, like Dr. Sergey said, is cleaning and cleaning and cleaning. That virus has a fat coat, a lipid coat. You just wash your hand, soap and water, 20 seconds. Like probably everybody has been talking about it all over the media. There's no need to re-emphasize it, but that's probably 70-80% of the job is good cleanliness. And so far that Amazon box or picking up from your shopping convenience store, I think the experts are saying the risk is pretty low to pick up from there.
Yeah. Absolutely.
Thank you,
I have a
Dr.
question.
Fadi. Yes, go ahead.
It's Father Joseph from St. George Cathedral in Coral Gables in Miami, Florida.
Hello, Father.
Hi, how are you? Thank you for what you are doing. Thank you, Sayyidna, for allowing this to happen. And thank you for all of those that organized this. My question is with regards, 2 questions, a very quick one. First of all, I have very young children. I have a 2-year-old, 2.5-year-old, and then a 9-month-old. And my concern is, even as much as I try as a priest to go out there, do my social distancing, but somehow, God forbid, we will also be at the front line with you. We pray for you. We are there for you, behind the scenes, praying for all of you. But also, if we are called to go to the hospital and to serve, we're ready for that as well. My question is, my concern is if we are asymptomatic, like I come back from praying over somebody. I had a funeral last week, for example, and I do catch something, and then I have my child, my children. What should be my concern with regards to children? How can I prevent? What steps can I do in order to keep them safe? And if I do have something, I mean, what do I do from there? And then my other question is, can the virus live on the skin, even if it's not the hand, but if it's on the skin, for example, or whatnot, and then I end up taking a shower? Will I get infected? Will it come in, or is it just respiratory? Is it just saliva? Is it just, those are my 2 questions. Thank you.
Yeah.
Thank you for the question. Jessica, if you could start with the response, please.
Yes, absolutely. So if you were to develop symptoms, I would definitely recommend sleeping in a separate room, trying to maintain that self-isolation so the rest of your family does not get it. Reinforcing hand hygiene, high-touch wipe downs. The CDC actually does have specific guidelines for what to do if you are in self-isolation or self-quarantine, utilizing different eating utensils, specifically cleaning those high-touch areas in your home. We do recommend also that if you were to develop symptoms, contacting either your health department and trying to see if you can get tested, and that would help kind of mitigate some of those instances. Now, as far as it living on the skin, if you were to take a shower, normal washing, that's going to wash away all of the fomites. So that shouldn't be a concern. But really just reinforcing hand hygiene, you know, soap and water for 20 seconds or alcohol-based hand sanitizer, and really just minimize the amount we're touching our faces. And so that's going to be your best bet. If you do go into the hospital and you are seeing very sick patients, my I actually would probably be surprised if you are seeing patients that are either suspected or confirmed COVID-19 patients, because most places in the country are moving towards zero visitors whatsoever. So that may help try to mitigate some of those fears. But just as far as like a general rule of thumb, if you are visiting sick members, really following the hospital's protocols, as far as like wearing like an isolation gown, gloves, performing hand hygiene, just the basic principles that we would do for any sort of infection prevention.
Thank you, Jessica. Dr. Sergey, do you have anything to add to that?
Yeah, I completely agree, Jessica. Great, all good points, most important ones. I mean, asymptomatic transmission, it does exist. We don't know how significant that is. I would think that if it does happen, which we know it does, but it's not as robust as if you were symptomatic. So, you know, if God forbid you would come in and you had a virus shedding before you get sick in the next couple of days, I don't think the transmissibility is great. It theoretically can happen, but I don't think it's very likely. And the second point is that we have good data from China that kids don't get sick too much. So they've had some kids have gotten sick, but none of them did poorly. Everyone went home. So something to reassure you.
Perfect. So, Dr. Sergey, I'm going to have you start off this next one. We have a lot of questions. We're going to try to get to all of them. In the interest of that, I'm going to move this along. The next one is from Jorge Christine Ritter, and she asks, if you have a dry cough but no other symptoms, is it possible to have the virus?
Studies have shown that basically everyone who came into the hospital and who was diagnosed with coronavirus, ultimately pretty much 100% had a fever in the end. So it's possible to have no fever when you first come in. We have a data from US, I think, that only half had a fever at the presentation, but ultimately fever will develop. So having dry cough that just lingers with no other symptoms, I find it not very likely. Having said that, you know, we still are learning about the spectrum of manifestations of the virus, which we know can be from anywhere from lack of symptoms completely to someone who can be in respiratory failure. So I think it's a possibility. I don't think it's very likely. I think it would be, I would just try to stay at home, not to expose anyone. And, you know, if the testing is available, you can get tested, but without the fever, I find it not very likely.
Thank you, Doctor. I wanted to move quickly to this next one, and Dr. Fadi, I wanted you to start this response. The question comes from Laura. Is there a way to stop the virus at the point of entry, nose, throat, before it gets to the lungs? And what would you recommend for asthmatics?
That's a good question, really. As I said, we are still trying to understand this syndrome. Since the data started surfacing from China, and as you know, from a pulmonary standpoint, trying to find out what have they been seeing from the lungs perspective. Because let me step back and just, now that we are so immersed in this, you know, self-education and learning from epidemiology with hands-on kind of while the virus is raging around us, I don't know if the other colleagues argue with that. You have 2 or 3 things that are interacting. If you go out to your car nowadays, you see this thick yellow coat on it. We are in the peak season of pollen. Allergies can give you a lot of the runny nose, scratchy throat. Some of the predisposed allergic, sometimes a low-grade fever can happen. So you got this one, which I hope all of us would get it and solve this entire pandemic with it. A little Claritin or a little antihistamine will solve it. But that's on the one end of the spectrum. You move to the middle, which we deal with it every year, which is the flu, which still has more mortality that already has occurred this year than the coronavirus itself. The problem with that, which I've been trying to understand, is that the flu comes almost with the same symptoms, but you have the fever, like Dr. Sergey mentioned, the body ache, the myalgia, the muscle ache, the cough, and the sore throat. But it stops there almost. You go to the emergency room or the walk-in clinic, and you do a chest X-ray. In a flu patient, you shouldn't, or ideally, we don't see anything on the lungs. This COVID-19, which is now officially, we should call it the SARS coronavirus 2, to distinguish it from the SARS coronavirus 1 18 years ago. By the time they're hitting the medical attention, they have something on their chest X-ray. And that's the difficulty of this virus, is that by the time it's showing for the patient or for the individual to seek medical attention, it has some pulmonary involvement. So these are the three kind of, in my mind, that I've been trying to categorize them. Back to, I hope I didn't make it too long. So back to the asthmatic, which all the teaching from Dr. Fauci that we've been hearing or following on an hourly basis on the news, is that we are considering the chronic lungers, basically asthmatic, emphysema, chronic bronchitis, anatomically distorted lungs, lung condition, and there are a lot of them, or the other immunocompromised. We're talking heart disease, chemotherapy, etc., and diabetes. They're mentioning more and more. That you cannot tell if your mitigation is really stopping that. Like Dr. Tarabay mentioned earlier, the mode of transmission is close contact, and unfortunately, touching your face and inoculating your nose and nasal passages. That's where the scary part of it, and I don't want to be scary, is that it sits down and multiplies in your nose and back of the throat without symptoms. And I think, and we don't know, the data is coming out and we are learning still, is that you can transmit it while it's still in your throat and you are not having a symptoms. So for the asthmatic, definite social distancing is the emphasis. So thorough cleaning, washing, disinfected, like Jessica, but I don't know if Jessica will have something more to add in this regard.
Yes, Jessica, I was going to go to you with the next question, but is there anything you wanted to add before we moved on?
Yeah, I think also really just kind of whenever we are trying to distinguish the difference on, is it COVID? Do I have allergies? Is it the flu? Is it just a common cold? So really just trying to identify those. As Dr. Fadi, he did mention we are in allergy season. And so, thinking about with allergies, allergies are not spread. COVID symptoms have not included itchy, runny nose, sneezing, watery eyes, anything along that line. So I think, having asthma does make you at greater risk as far as a pre-existing condition, but we're still learning so much new data. So we have race and ethnicity as from China, we have China data, we have our European nations, a little bit of data regarding that. So what we're starting to find here in the US is our race, our population, and our socioeconomic status, some of our cases are looking very different. And so really just keeping that in mind, and as we're trying to determine who's at greatest risk and so forth. So that's just a little bit more.
Thank you, Jessica. I was going to start with you for this next question, and then I'll go to Dr. Sergey. Sarah Hodges asks, what are your projections about the life cycle of corona, i.e. when will gatherings resume, etc.?
Yeah. So that's actually really hard to say, right? So we don't know what the numbers, and yesterday we have bypassed our numbers, and our mortality rate has bypassed more than any other country. And that is without adequate testing. So as far as, when are these gatherings going to occur? I will say here in Georgia, we're on a steady incline. I think that we will be probably start to reach our peak within the next 10 to 12 days. But as far as some of our other areas, it's really hard to tell. There's really no way to tell exactly what we're dealing with as far as social distancing, if that's even helping, without adequate testing. So still more to come. I know that there has been discussion on maybe some states would move faster than others. That's again really more presumptive and not driven by data, which epidemiologists and infection preventionists and physicians, that's really what we need to kind of drive those decisions. It's specific data.
Thank you, Jessica. Dr. Sergey, do you have anything else to add on the life cycle and what you're thinking in terms of when gatherings can resume?
Yeah, I agree. It's impossible to tell. I mean, in China, as you know, it took them 2.5 months just to stabilize the situation. And this was with draconian measures, which will not be employed in US. So I think it'll be harder to contain it here than in China, unfortunately. And I think there's going to be a marathon. I look at it as a long haul. I mean, I don't think there's any month anyone can give you. Some people say June. We may reach a peak. I think peak is still yet to come, of course. We're just starting to see this uprise. So I think we'll just have to stay put and and get ready for a little bit of a long haul, I think.
Great, thank you, Doctor. I'm going to move to the next one. We have a lot of questions. Again, we're going to try to get to as many as we can. And again, I want to remind everyone we will be posting the recording of this for anyone that joined late, or if you want to send it to family or friends to watch after the fact. The next question, I'll start with you, Dr. Fadi, on this one. This is from Susan Cushman to everyone. What do you think about using zinc lozenges to block the coronavirus? I heard about these from a physician who says, stock up now with zinc lozenges. These lozenges have been proven to be effective in blocking coronavirus and most other viruses. This is the quote from that physician. From multiplying in your throat, use as directed several times each day. When you begin to feel any cold-like symptoms beginning, it is best to lie down and to let the lozenge dissolve in the back of your throat and pharynx. I don't know if I said that right. Dr. Fadi, I don't know if you can comment on that specific question about zinc lozenges.
Again, this is one of the many things that you are hearing about, like they have been described. Some to a better extent are more scientifically at least proven, but all fall under the category of anecdotal. Meaning, I don't want to say hearsay or he said, she said kind of thing. Ordinarily, in the routine practice, I'm not aware of zinc lozenges being used to start with, much less than in this wild world we are living and trying to navigate through. If you start having sore throat as one of the symptoms, and if you have fever, instead of sucking up on zinc lozenges, you better ask your local doctor and health unit, where can you be tested first? Because this way you have removed yourself from the asymptomatic to asymptomatic, and for this category, the test is indicated at this point in time in order to know about you and to seclude you at home, quarantine you, or to be in the hospital if you have significant symptoms.
That's great. We have so many questions. I'm going to combine the next two, and I'm going to actually go back to Dr. Sergey to start this one. So the first question is from Ray. In consideration of the likelihood of creating a vaccine, has the COVID-19 mutated or is it expected to do so? And the next question is from Sarah Hodges, who asks, does antiseptic mouthwash help prevent the virus from entering the lungs? Dr. Sergey, could you start the response on those two question responses?
The virus doesn't seem to have been mutating as much. I mean, it does have that it's kind of a usual rate of mutation because it's an RNA virus, so there is no proofreading with it so much. So it does have that regular mutations that will occur, so you kind of trace it epidemiologically in that regard. But as far as the virulence, it hasn't changed to my knowledge. So I don't think, again, to my knowledge, that it's really early with vaccine development that is going to really impact the vaccine. But the coronavirus is not straightforward with vaccines. I mean, when you develop a vaccine for this virus, and I'm not a vaccine expert, but what I've heard is that sometimes immune response can be more damaging than the infection itself. So it's really not straightforward just to come up with a vaccine. I know they're studying several candidates, but we won't have and I'm sure you've heard that already, we won't have a vaccine until 1 year from now at the earliest, probably a year and a half. So not going to happen this year. I'm not sure if virus mutation will play any role in this or not. Doesn't seem to be right now. In regards to antiseptic, I am not aware of any data clinically for this. I mean, alcohol works on the surfaces, but you're not going to drink alcohol 60%. Not every antiseptic works the best. And for example, chlorhexidine, which we use for mouth rinse, doesn't seem to be as good on surfaces. So in the mouth, it probably won't be as good either. So I'm not aware of any data. Maybe there's something that came out that I didn't see. I would not be rinsing it myself, or I wouldn't recommend it to my patients on a regular basis. I just don't see that would really be helpful. I think it's more important just to prevent infection as much as you can, stay healthy as much as you can. And really that's all you can do, but yeah, thanks.
Thank you, Doctor. I really want to try to get to as many of these questions as possible. We have a lot of questions in chat. I encourage everyone to continue to send those questions. We'll try to get to as many as possible. I actually want to start with Dr. Fadi for this next one, and then I'll go back to you, Jessica, with the question after. Dr. Fadi, I'm combining two questions. The first one is from Alfred, who asks or says, it has been reported that there can be long-lasting lung damage if affected by the coronavirus. Can you give detail on what type of damage happens to the lungs? And then Sarah Hodges is also asking what percentage of people going onto a ventilator survive? Dr. Fadi.
Yeah, good questions. We are all in this learning curve. So far, what's been reported from what I could gather from the studies, limited amount of published data from radiographic studies. Basically, a CAT scan came out from the CAT scan series on the patients that they were able to do on them. And this is where you would start to see findings. And these are radiographic findings. I don't know if I'd be too helpful by describing them in lay terms, but there is some description of haziness or shadows, what we call it the ground glass, but also some fibrotic changes. We have not even gotten out to the other end of the tunnel to control the virus, to see on a controlled setting after they've been cured and they've been safe and they've developed immunity, to bring them over to the clinic and to do population-based pulmonary function test. That's the only good answer objectively to be saying after all of that calms down, is those who had the syndrome and got treated and came out of it. And this, remember, it's more than 85% will come out of it, even if you get the virus. Is to do, and I'm sure we're gonna have plenty of studies on a more controlled basis, on a more peace of mind, normalcy type of back to our profession and function, where we do what we call it, office spirometry or pulmonary function test. Then we can tell if there has been any lung damage in their function. As far as the X-ray, as long as it has not affected their lung function, there could be some scarring. And we do this, we do see it as bread and butter of our profession, is scarring on their lungs for something that happens 10, 15 years ago. And it's a scar. It's like you take a picture and it stays with you. It doesn't affect your day-to-day breathing, etc. That is what is not of an imminent or immediate impact on what we are interested in. You may be left with some scarring, but without any effect on your lung function. So what? As if you have a mole on your forehead or on your skin, and you carry it with you your entire life. That's nothing. The other part of the question, or the second question, again, we don't know what the percentage of people going on the ventilator are making it without any sequelae. A lot of people are getting off the ventilator. It's not everybody who goes on the ventilator is dying. Sorry to be blunt like that saying it, but the syndrome is there. We are seeing the mortality when they go on the ventilator, which again, this is another question in my mind. Why are they dying if they're going into that acute respiratory distress syndrome, which we deal with it as part, bread and butter kind of for the pulmonologist and the intensivist. Yet people have not been dying from the ordinarily described ARDS that we've dealt with it for years, the way this virus going on the ventilator with ARDS is dying. There's a lot of data we don't understanding. Those poor epicenter medical centers, we're leaving them alone. They barely are making it to get them through. The information I'm sure will come out later when that curve that everybody keeps talking about it, when we bring it down and things calm down and hospitals and medical centers are able to function normally, then we will have a lot of data in outcome and other factors.
Thank you, Dr. Jessica. Did you have anything to add to that response before I ask you the next question?
No, I think that's pretty spot on. And again, like I think, yes, with ARDS and people that are going into a complete severe disease as part of their immune response, it does make it difficult. And what really makes it difficult is the more and more people kind of hitting that stage, and then the ventilators. It's not necessarily meaning that ventilators that means a very poor outcome. It just also means we also need to make sure we have enough resources for that as well. So that's just a little caveat to it.
Got it. Thank you, Jessica. I'm going to combine the next two questions again in the interest of trying to get to as many as we can. The first one may be a very quick and easy response from you. This is from Elijah. Should we be avoiding elevators in order to avoid the aerosolized virus? And then the next question is from Dale. And this is similar to an earlier question, when we bring in food from the grocery, should we be washing and wiping everything down? Also, when we bring in takeout food, do we need to bring only in food that we can heat up to kill any virus? Is that effective?
Yeah, so those are excellent questions. Let's start with the elevator. So whenever we say aerosols, that's basically generated. So this virus is a droplet virus. And that means that really why social distancing is such a huge factor is maintaining that 6 feet away. So droplets are very heavy. They basically can shoot about 6 feet and then they drop to the ground, and that hence is why we say it's contact and droplet transmission. So those surfaces could have those fomites, and then it could be in as far as like transmission with droplets with that 6 feet. When we say it's aerosolizing, so things that would be aerosols or that would cause aerosols would be aerosols generating procedures. So typically you're going to see more of that in specific hospitals. So what's going to generate that cough? What's going to go down into that person's respiratory tracts? So, in the community itself and going into an elevator, that's not necessarily as big of a concern for us, but what we would want is that, if you are touching elevator buttons, performing hand hygiene before and after. So really just keeping those sort of mindful things. If you do touch an elevator button, don't immediately touch your face. Those are going to be the best ways to protect yourself. Now, as far as food, I'll tell you right now, like that's what I've been kind of living on, those takeouts. And so I'm not wiping it down. I'm not re-washing my food as far as that goes. But as far if you go into the grocery store and you pick up apples, yeah, I would absolutely wash those as you normally would before eating, and just taking those specific precautions.
Thank you, Jessica. Dr. Sergey, do you have anything to add to those question responses?
No, nothing to add. Everything is covered.
Okay, wonderful. Well, I'll start with you, Dr. Sergey, on this next one. This is a question. I use a sinus rinse during the spring to keep congestion down. Is this something that would also be helpful to clear the virus? And then the next question I wanted to squeeze in here from Bishop Nicholas, who just asked, what's the difference between a ventilator and a respirator? If you could answer those two, Dr. Sergey.
The second question is probably more along Dr. Fadi's lines, but no, I don't think we know that sinus rinse will wash away the virus. A virus receptor is in deep lungs. Okay, so it's not gonna. I don't think it's gonna sit in the nose. That's why it doesn't really cause the runny nose as much, because it doesn't have a receptor in the upper airways. So, rinsing sinuses is great, but I don't think, or I'm not aware of any data that's going to do anything for the virus itself. It's nice to have healthy airways from that point of view, but this is not where the virus really acts. So I don't think it's going to really help in that regard. The ventilator is a mechanical ventilation, but maybe Dr. Fadi can answer that, because it's really his.
Yeah.
Yes, Dr. Fadi, please,
Yeah.
if you could.
Hey, Sayyidna, I know you're pretty medically inclined. Ventilator is basically when the pulmonologist or the doctor is talking with his respiratory therapist in the ICU, in the hospital setting. That's the technical professional. If he gets out to the consultation room to update the family, I'm sure probably if you asked have the pulmonologist or the intensivist in the country, they would have explained it or used the word respirator. It's the same principle. The question here, while we're at it, let me just open a quick parenthesis, is that the ventilators we're talking about in the hospital, in the ICU, is when the patient is intubated. That is a plastic tube that is going through the mouth into your trachea, into your windpipe, and basically you are totally sedated and your will is taken over from you, and the machine is doing the whole job for you based on the parameters that are set up by your response on the arterial stick that we do as an arterial blood gas, without going too technical here. However, there are a lot of ventilator or respirator that are not that invasive. That we call it invasive. We invaded your privacy, your human body, by going in with the tube into your throat. Half of what I see from the sleep apnea population that we give them, these are masks that you put on your face every night with a CPAP or a BiPAP or an AutoPAP. But there is a little version to this using the same principle, which is nothing but a ventilator that we've been using for several years right now in their home environment for the bad emphysema, those who have a chronic, their respiratory system has failed on a chronic basis, but they are functioning in the daytime. Those, we put them on a ventilator or a respirator without going through their mouth or their throat. They're putting basically a mask. And just to throw in a little quick joke, part of the frenziness that's going on, I have my next door neighbor, lawyer, he shows up as a patient, basically wondering that if I can test him for sleep apnea, because in the case of he wanted a machine to be used as a ventilator for him when the moment comes. So of this epidemic we're talking about. But that's the 2 cents explanation between respirator and ventilator.
And actually, Dr. Fadi, I'm going to stay with you for this next one, because this question has been asked quite frequently. I'm actually going to skip down to a question from someone asking, should people be wearing This is from Sam Mosier. Should we lay people be wearing PPE, personal protective equipment, such as masks when going out? Since none are available, what should we do instead besides rigorous hand washing?
I mean, the answer is really in the question. He answered it, Sam. No, if he's not immunocompromised and he's using the social distancing and he doesn't have a need to go do unnecessary socialization, just get his shopping, do necessary, fill up the car with gas and come back home, use the hand cleaning and those 20 seconds regular, vigorous and rigorous hand washing. With the shortage they're talking about, like myself, I've been putting those two on top of each other, and I'm trying to, avoid, but just for the office, the visitation, with the shortage that they're talking about, lay people know they should not use the PPE. I don't know if Jessica can have a word along that line from an epidemiology standpoint.
Jessica, anything to add?
Yeah, I absolutely agree with everything. We're not recommending utilizing PPE. I do not wear it in the hallways here. I do not wear it out in the community. Really, when you think about PPE, that kind of generates more of us touching our face. It's uncomfortable. Masking, it's hard to speak. So it brings more attention to constantly touching our face. And so really just reinforcing hand hygiene and just minimize, and like specific, I mean, just general hygiene in general, minimizing the amount we're touching our faces. So don't recommend utilizing mask. And I mean, there's also a lot of discussion on cloth mask right now. That's also not another recommendation either. So just got to be careful with all of that. I lost sound.
Oh, I was muted. That was my fault.
Okay.
I was doing well until then. I'll start the next question with you, Dr. Sergey. This is from Sarah Hodges. If someone is isolated on a different floor of a house, would the lack of a door be important, or do you need to create a drapery for the door to make the quarantine effective to draw a line for someone returning from Madrid, for example?
I mean, distance is more important than the physical door, because as Jessica said, the droplets are heavy and they will not travel for too long. You know, if someone who's violently coughing, you probably want to have some kind of a barrier, but without aerosolizing, method, something that will expel particles on longer distance. Not coughing, I think distance of 6 feet and more would be sufficient. If you have a door, that's better, but without the door, as long as it's far enough, especially different floor, I think that should be sufficient.
Thank you, Doctor. I'll start with you, Jessica, for this next one. This is from Rachel. I've been seeing posts about the need for blood because of mass blood drives getting canceled. There are small local blood drives taking place near me, and I was considering giving. How high is the risk of being exposed when giving blood? Jessica, we'll start with you.
Yeah, that's a great question. And hospitals are absolutely at need for blood. There is no risk with that because they're screening people. If you have any signs or symptoms, recent travel, they're screening like crazy with that particular piece. And so you're not at any greater risk to donate blood.
Okay, great. I'm going to move to the next one. This is from let's see, Father Joseph Landino says, is stomach pain a symptom of the virus? Father Fadi, I'm sorry, Dr. Fadi, maybe you can comment on that one.
Stomach pain?
Yes, is stomach pain a symptom of the virus?
Not that I'm aware of being described. We talked about the three upper respiratory with fever, sore throat, cough, but also now, as Jessica mentioned, the loss of taste bud that I haven't, I'm learning about it too, but I'm not aware anything about below the diaphragm, so to speak.
Dr. Sergey, I don't know if you have anything to add on that or if your response is the same.
No, abdominal pain, I haven't seen it. There's a rare proportion of diarrhea, in a range of 5%, perhaps, maybe 10. But I think those people who have that kind of a symptom, they also will have respiratory symptoms too. So, I mean, if someone's coming in with coughing and a fever, but they also have some loose stools, I don't think that should dissuade providers from testing for COVID. But I don't think diarrhea alone or abdominal pain in a lack of respiratory symptoms should be likely.
Thank you, doctor. This next one is a very interesting question. This is from Matthew. It looks like it is difficult to know what to believe in today's news media. As medical professionals, do you recommend any particular sources who have been reporting accurately? Dr. Sergey, what would your response be?
Well, I get bombarded with a variety of sources. I mean, tens of emails per day. I mean, CDC is probably the most reliable source. So I would definitely use that as a number one for especially non-professionals. They really digest things for you and they update it regularly. I mean, otherwise, you know, Medscape I like, but it's more medically oriented. I mean, I use JAMA, Lancet as well, and New England has a nice COVID oriented, but it's all more medical language stuff. So I think I would start with CDC, and then you can expand on it if you know, more medically inclined. You can go to those JAMA, Lancet, NEJM.
And Jessica, did you have anything to add on that?
No, absolutely. I absolutely agree with everything that he said.
And Dr. Fadi, are you also in agreement?
Yeah, I would add, in case those sites that Sergey mentioned are too heavy in the medical terminology, the CDC, but also your local, depends on where you are. I think state by state, the governor's site and the health department of each state, and then all the way down to your state, local, and city. Each city, I'm sure it has its own health unit, and especially if it's starting to see cases and so on. And so you gotta use your local information. Otherwise, you know, if you're watching news and you wanna be balanced, you switch between CNN and Fox and go from there.
Okay, and Dr. Fadi, I'll stay with you on this next one from Jesse Cox. I am an RN. At my hospital, they have stated that if we are exposed outside the hospital, we may return to work 7 days after exposure if we are asymptomatic and cleared by our employee health. Is this an adequate amount of time, or do we need to continue isolation for a full 14 days?
Again, we're going here to individual situations. Again, the data that I'm aware of is that the incubation period, that's what you're gonna go by. And here we're assuming that the nurse was in contact with the confirmed case. If that's the situation, he was in direct contact with the confirmed case that was tested, then the incubation period for the close contact to that index case, we call it, may not show for 14 days. Some are saying longer. But the tricky part about this virus, as we've mentioned a few times now, and for the sake of time, is that you may be transmitting it when you are asymptomatic. But I think this is all in the department of Jessica. I will yield the time for her to add this answer.
Yes, Jessica, please.
Yeah, so what we're knowing right now is the risk of community transmission is very high right now. And so if you were to have a direct exposure again, a direct exposure, we're honestly just recommending to our staff to just monitor their symptoms. Still, the risk of transmission asymptomatically is much lower. Yes, it can occur, but it is much lower. We're asking people, if you're symptomatic, you stay home, you self-isolate, you get tested. And then, you know, before their return, but basically, if you do become symptomatic, you want to make sure, as with any influenza-like illness, that you're monitoring your temperature, and you must be fever-free for 24 hours without fever-reducing agents. And so, you know, I would say it's going to be very different based on your institution's policies and protocols. But we really need to make sure that all of us are monitoring our symptoms. We're all staying home when we're sick, and really just trying to determine what our symptoms are. And so I think it's an excellent question. I know it's kind of murky as far as the answer goes, but everybody, just as a rule of thumb, stay home if you are sick.
Thank you, Jessica. I'm going to combine the next two questions. There's one from Jeremy. Should I be gargling with warm salt water? And the second part is from Laura. If the mortality rate is so much higher than the flu, why are there so many more deaths from flu each year? Or are these death rates going to eventually rival the flu? Dr. Sergey, would you mind starting with a response to each of those?
All right. Well, we already had a few questions in regards to gargling and rinses. I think that's same answer. I mean, we know that virus doesn't like high temperature, so theoretically, sure, if you feel you want to do that, I don't think it's necessarily a bad idea, but I am not aware of any studies that have proven the effect on the human. In regards to, I'm sorry, what was the second question?
Yes, the second one is, if the mortality rate is so much higher than the flu,
Yeah.
why are there so many more deaths from the flu each year?
Well, not so many people got sick compared to flu. I mean, unfortunately, we will see increase as we're seeing every day. I mean, it is definitely at least 10 times more fatal than the flu overall.
Okay, the next question, would you, Dr. Sergey, comment on this, and then I'll go to Dr. Fadi on it. And, can you comment on the drugs, the efficacy of the malaria drugs being discussed as possible treatment for the virus? That was from James, and then there's another comment similar to that. Can you comment on the drugs hydroxychloroquine and chloroquine? Can you comment on that?
So yes, there is a preliminary data from France. There's a group in Marseille that has recently looked at hydroxychloroquine combination with azithromycin. So this is all evolving. I mean, we are using the data, what we have. It's not as robust. It's not really like randomized controlled trial kind of data, but basically it's being employed in probably majority of the hospitals, but it's employed for patients who need it. You know, we don't give it for someone who is minimally symptomatic. We have certain criteria that we use these kind of medications based on the enrollment criteria that they used. So a lot of universities throughout the US have adopted these in various forms. So they have their use. The data is still evolving, but they are being used.
And Dr. Fadi, do you have anything to add?
Yeah, well, I think it's all over the news. Probably we don't want to repeat known information. Malaria drug, the hydroxychloroquine, has stood the test of time since the 50s in terms of the relative safety. It's not totally benign. You got to have just one word of caution quickly here. I'm going to zip through them. You're going to have a clear EKG because of a condition where you have a prolongation in certain conduction in your EKG, your heart tracing. You're probably at a disadvantage of trying to use it. Bottom line, the local hospitals, out of lack of anything else that is randomized, proven, have adopted the combination of 5 days of hydroxychloroquine with azithromycin, the very well-known Z-Pack, basically. But that you have to be symptomatic. Do we have data? Do we have like what Professor Fauci has been preaching? Do we have it scientifically proven? It's hands on deck, as we are, the word we learned in this amalgam of what we're dealing with. Sort of anything that you don't have at hand, this drug has basically a low side effect profile over the years. And as Sergey said, there are some data showing up from France, and has known not only anti-malarial, which we grew up learning in med school, and that's the indication where it was used, but it has an antiviral effect. How robust, how efficient, how eradicating or virucidal, we call it, and so on. That is an open question, and I think a study is needed, and I'm sure all the authorities with a subject like that, this is what they're going to be orchestrating in a more stable condition. But I leave the last few minutes to Jessica too, because that's in her realm to end with it.
Go ahead, Jessica.
Specifically as regarding for treatment or sorry, what was the question?
Oh, just the, I think we were talking about the efficacy of the two drugs, the malaria drug, and if you had any additional comments to add on what you've heard.
Yeah, no additional comments. I mean, we do have adjunctive treatments. We're not sure of unclear benefits with that. Again, it would still be limiting unnecessary antibiotics in confirmed cases to avoid other adverse events and require longer hospitalizations. But no, for moderate, severe disease or symptomatic and high risk patients that have a poor outcome, those two drugs are what we're recommending.
Thank you. We are actually at time. It's already been an hour. Time has flown by, and we want to be respectful of our medical staff because they are working very hard in their respective fields to help fight this virus. I just want to thank all three of you very much. Jessica, Dr. Fadi, Dr. Sergey, thank you all very much for being on this panel, for your wonderful responses, just that are so helpful to us as lay people that don't understand what's happening. I think everyone has really learned a lot, and we've had a lot of good questions answered. So thank you very much.
Thank you, Mike. I may say for being a great moderator. I think you're almost getting a pro and professional, and that's why Sayyidna knew whom to choose to orchestrate all of that online activity. So thanks for having you on board moderating.
Thanks, Peter.
Nice meeting you, Jessica. Maybe you can chat
Very
some
nice
more.
to meet you. Yeah, for sure.
You're
right.
from in my old alma mater at Emory, I see, but we'll talk some more later on.
Yeah, very good. Very good.
Yeah,
Well, thank
Sergey.
you.
Well, thanks be to God. I appreciate your words, and thank you, Dr. Sergey, as well. Thank you again for joining. We will get a recording of this out for people who weren't able to join live. And if we didn't get to your question, we apologize, but again, want to be respectful of everyone's time on the medical staff. Have a great rest of the week, a great weekend. Talk to you all again soon.
Thank you, everyone.
Yeah,
Bye-bye.
please stay safe, everybody. Bye-bye.